ureter has been completely dissected out. You can see the obturator nerve. So it's a very complete dissection, and yet we did not have to open the abdomen. When I began my training to be an oncologist a number of years ago, and these operations were being done open, patients were in the hospital for 5 to 7 days. The average blood loss nationally was about 800 to 900 milliliters. When we do this operation now with the laparoscope, our patients go home in 18 hours, and the average blood loss to do a radical hysterectomy this way is 50 milliliters. And yet the operation has equal efficacy. So it shows how dramatically we've moved forward in our success for treating patients and doing so with less burden on their health to recover. The last few slides that I would like to show are the radical trachelectomy. This is again a schematic representation, but it gives you an idea of how we do the radical vaginal trachelectomy. But I'd spend a moment first to say who is a candidate for this operation, and the key is up here. Our patient can have a lesion up to 2 centimeters in diameter. It's critical that we not do this operation for patients with lesions larger than that. And I'll show you a table with some numbers of why, but it's because the failure rate is so high. But as long as we carefully select patients with cancers smaller than 2 centimeters, this operation has an equal success rate on curing the cancer compared to radical hysterectomy, and yet she still retains fertility. So the operation begins first with a laparoscopy to remove lymph nodes, because we still need to know the status of the nodes. Then we begin vaginally, incising partially down the length of the vagina. So this is not the same as a vaginal hysterectomy. Once that space is opened, we then will dissect out the ureter. So in a regular vaginal hysterectomy, normally this is never seen. But what we do is we open spaces between the cervix and the bladder, and between the cervix and the pelvic sidewall. This allows us to see the ureter. Once the ureter is safely moved up out of the way, we place our clamps on the ligaments. So this is doing exactly what a radical hysterectomy does. It takes out the broad ligament, but we will then leave the upper part of the uterus here by cutting off only the cervix and the upper vagina. The very last step is that we place a cerclage. This is a permanent stitch around the cervix, much like a purse string. And this is a permanent suture. The intent is to help hold what remains of the lower uterine segment shut so that it does not prematurely dilate on future pregnancies. And then this edge of the cervix is then sutured to the vagina. How well does it work? There are a number of institutions around